Good morning. So I would like to thank the organizers for inviting me to this nice conference, and I hope that next time we can be all in person in Vellore. I've been asked to discuss about inherited bone marrow failure syndrome in children with aplastic anemia. How common are they? And I'm speaking from Saint-Louis Hospital in Paris. So aplastic anemia is a rare disease, 2 per million in Western country, more frequent in Asia, 4 to 6 per million. And there are two age incidence peak, young adults, and later in life in elderly, meaning that it's uncommon in children. And it points out already that in children, genetic cause can be more frequent. As you know, the most frequent cause is immune, of 70%, about 70% of the acquired aplastic anemia. It can be viral, toxic, but there are genetic causes, what we call inherited bone marrow failure, the most frequent being Fanconi anemia, also dyskeratosis congenita, many others. And there are emerging causes that are more and more recognized, like 79L, CXL2 and others. And they are increasingly recognized by the community. And this is important to diagnose them because they will impact the treatment with immunosuppressive therapy that will not be efficient, that will impact the stem cell transplant, the regimen, the donor choice, and the follow-up of the patient, especially regarding the cancer risk and also the family counseling. We think that at evaluation of a patient with a suspected new diagnosis of aplastic anemia, 5 to 15% of adults with present of those patients will have an inherited cause. And this is probably about 25% or more in the children, knowing that aplastic anemia is a diagnosis of exclusion. So the workup at diagnosis is essential, and obviously it will be oriented by the presentation. The clinical exam is very important, especially if positive, if there is a short size, abnormal sums, and so on. The depth and dynamic of the cytopenia on the blood cell counts are very important as well, knowing that in RR this is often very brutal, while in genetic causes the evolution is more progressive. If there is a PNH clone, this is an important criteria for acquired immune aplastic anemia escape. So it is important to search them. And the chromosome breakage tests are still very important, as well as telomere length. We perform them in all young patients. We'll discuss the age, but in France, we are doing that systematically if there is no, even if there is no sign at all, before 20 years old of age. And the panel with all those genes can be done systematically or depending of the clinical sign on the age. We will discuss that again. And this is well discussed in those types of paper on guidelines. So today there is no universally recognized guidelines, and I have put that paper to you from Ami Dezern and Jean Soulier in Blood Advances last year. And the important points in that algorithm, like in others, important points are always the same. This is a personal or family history, the age of occurrence, and the potential lack of response to immunosuppressive therapy, and the potential progression to MDS, AML, even if it's not a criteria of genetic cause, but still you will even more necessarily know, will have the need to know if this is a genetic cause or not. So the most frequent of the genetic cause is still Fanconi anemia. As you know, the diagnosis is done mainly during childhood when the cytopenia occurs. Sometimes there are congenital signs that have a real value to suspect the diagnosis when they are present. They can be all absent. And at that stage, usually the diagnosis is very easy by doing a chromosomal break stage. testing the specific phenotype of the cell. And because we are lucky enough to have a phenotype in Fanconi, a cellular phenotype in Fanconi, which is the hypersensitivity to intercell cross-link, either deoxybutyne, either mitomycin C, that makes these typical breaks or radials in the cells. And at that stage only, we sequence the FANC gene. We have a dedicated panel for the 22 known FANC genes, and FANC A, G, and D2 and C represent most of the Fanconi genes. But still, we do not perform upfront the panel because there are many, these are large genes with many potential variants. It is difficult to interpret those panels without a phenotypic test in parallel. That said, there is more and more cases that we are solicited because somebody somewhere has done a panel with FANC genes, found a variant, and they wonder whether or not it could explain clinical signs, whatever they are. And when we receive those type of demand, we we go on to doing the cellular phenotype on the cells. And we always keep in mind that there is a potential problem in Fanconi, which is the clonal evolution, either to transformation, and they can be confounding somatic mutation. But another possibility is for the patient is to revert, and some cell will genetically revert. They will mutate their mutation either by back mutation, either by uniparental disomy, or by crossing over mitotic. And these patients with somatic mosaicism, they are not that frequent. We find them in 15% and probably less now that we have a big cohort of true reversion. And usually the blood counts are mild or bitter, but it can blur the result by making them non-conclusive. So the typical presentation of a revertant patient is not aplastic, severe aplastic anemia, but if you have mild cytopenia or pancytopenia, you have to think before to formally avoid the Fanconi, especially if there are clinical signs that those patients can be somatic mosaic, and in that case, to rule out that, you have to perform a skin biopsy. So, as I said, there are many emerging cases and many unrecognized cases. And to clarify this, we performed a study 3 years ago, and all the patient samples we refer to the French bone marrow, we received in the French bone marrow failure laboratory over a 15 years period time. And we included all the patients with bone marrow failure of central origin, with or without dysplasia. And in all the patients that were likely inherited because they have, again, one of those criteria, physical abnormality, meaning personal history or family history of hematological disorder and or consanguinity, and or a young age. And in that series, we especially enriched patients with even less than 2 years old. But in that complete series of 179 patients, 1/3 of them were children and 2/3 were adults with a chronic evolution, which doesn't mean that it hadn't started at the children age. And the objective in that vast cohort of patients was to recognize, to clarify some unresolved, likely inherited bone marrow failure, identify new patient, new cause, and draw a broad molecular portrait of those bone marrow failure inherited. And we studied the skin fibroblasts to avoid any trouble with reversion or mutation, somatic mutation and clonal evolution in those patients. And the results are summarized here. We found known and unknown genes, some very well known like TERT or TERT or GATA2 and so on, but those patients were not recognized before because they did not presented with the prototypical phenotype of this keratosis congenita, for example, or phenotype of GATA2. And that was not very known at that time of the study. So that is an important point. This is that the patient can present without the typical phenotypic clinical signs. The second important point is that if you classify all these inherited genes that can be causal of bone marrow failure, you can classify them in a core biological pathway. And this pathway defines the pathway of the inherited bone marrow failure. These are, as I said, Fanconi anemia genes, and these are as well hematopoiesis transcription factor, especially MECOM, GATA1, GATA2, RUNX1, ATV6. I would say as expected, but for example, for MECOM, that was not well known. Telomere maintenance genes, this is well known, and some new pathway like SAMD9 pathway, I will be back on that. Ribosomal abnormalities pathway, you will heard about that again, and all this makes the FA core, the core pathway of the bone marrow failure. And again, the phenotype, clinical phenotype can be discrete. We tried to characterize that in that study by studying which of the patients with a mutation, like for example in Turk, had or not the typical presentation with this keratosis congenita. For example, here on 9 patients, 4 had the dyskeratosis congenita presentation, but 5 did not, meaning that you, even with patients without a typical phenotype, you have to push further to find a genetical cause. And another important point is that the landscape expands, but the phenotype of each gene expands as well. For example, some patients with a RUNX1 mutation will present with thrombocytopenia, but some other will present with pancytopenia, and other with an upfront MDS or AML. So, for example, for the SAMD9L, some will present without signs, and they can be diagnosed because they are in a family of other patients, or they will present with a severe aplastic anemia, or they can present as well directly with an immunodeficiency or a myelodysplastic syndrome. So you have to not stick too much to the phenotype of the patient, even if those phenotypes can suggest the disease, but it is not always the case. So in SAMD9 now will not be too long because I know you have a presentation by Marcin Wlodarski, who certainly will be back on those 2 genes. But just to say, they are located at chromosome 722. So a brief introduction, they are introduced at chromosome 7q21, and they were described originally because they can create 2 syndromes, SAMD9L, the ataxia pancytopenia syndrome, and the SAMD9, the mirage syndrome. And in both syndromes, you have myelodysplastic syndrome or pancytopenia, and this is due to an activating hematotoxic mutation that is heterozygous, so the transmission is autosomal dominant. And in our hands, in the recruitment we have in my institute, we more frequently see the patient with those mutations associated to aplastic anemia than myelodysplasia. And this is shown on that slide. These are the stories of each of the patients we diagnose. They have, many of them had a cytopenia, which is shown by those black circles. And some of them, many of them, but not all, have monosomy 7. It is shown with this gray area, but not all of them display only myelodysplastic syndrome, MDS, or an AML, meaning that in front of the severe aplastic anemia in the young children, it can happen very early in life at 1 to 2 years old. You have to look for, to search for SAMD9L especially, but SAMD9 as well, syndrome, even if you don't have the complete syndrome. And later in life, you can find those syndrome that can be very asymptomatic because of a somatic event that occur later. It can be a monosomy 7 that can be transient or not. That can be a unisomy monoparental or additional mutation in cis that will correct the aplasia, a bit like in Fanconi there is a reversion that will make a clonal evolution onto reversion, and it saves the patient, it rescues the cytopenia from the patient, while a minority of the patient will develop a somatic mutation with oncogene mutation or gene suppressor mutation, myeloid cancer mutation that will lead to MDS and AML. And this is very well investigated in many papers, including the recent paper of Marcin Wodarski in Nature Medicine. So this is important because it changed in practice the policy of treatment of those patients. In my institute, if the patients are very young with a severe aplastic anemia, even with monosomy 7, we wait a bit of time, probably 1 year, and it has to be discussed. There is no consensus to see whether those patients will spontaneously evaluate toward a reversion and spontaneous recovery, which is important because then you don't bone marrow transplant them, which obviously changes life. A second disorder, which is rare but that you can see, is the MECOM disorder, mutation in the MECOM gene, truncating mutation. And we saw several patients, 6 different patients, all de novo, with a heterozygous mutation inactivating MECOM in the zinc finger domain in all the patients. So all those patients presented with a severe aplastic anemia. We had one more with a deletion, a complete deletion in MECOM recently. They received a hematopoietic stem cell transplantation before 3 years old, but only 2 has the Rosat syndrome. This syndrome has been described previously in very rare patients with a malformation of the ulna, but in those 6 patients, only 2 had the presentation with an abnormality in the ulna, meaning that again you have to look for this syndrome and also the ROXA11 gene mutation syndrome in patients very young with an aplastic anemia. We had also this new syndrome, ERC6L2, that has been originally described with patients with microcephaly, but now we have more patients. Not all of them at all have the microcephaly, and they usually present if the entrance door is a bone marrow failure with a mild bone marrow failure, and some of the patients will develop, along with the T53 and monosomy 7, an evolution toward a myelodysplastic syndrome and or leukemia. And this is the way this syndrome has been described in Finland, where there is a founding event with the patient who have a biallelic homogeneous mutation on the same residue. And those patients most frequently present upfront with an acute myeloid leukemia. So same gene, a different presentation depending of the mutation. So now we have in France an updated myeloid panel in my institute. Today there is 148 genes that are a mix of the germline and somatic gene. We have the same panel for everybody, and we looked especially the germline gene when we suspect in a bone marrow failure or in a myelodysplasia an inherited cause for all the reasons we discussed before. And again, we perform that panel in every single patient that is 20 years or less, unless he has an obvious Fanconi anemia or an obvious dyskeratosis congenital that orientate the phenotype in that direction directly. So how to diagnose inherited bone marrow failure in 2022? Again, the clinical orientation and the phenotypic test are important. The fibroblast cells can be useful to rule out potential reversion, but it's not the typical presentation in aplastic anemia. We use, as I said, very easily the panel NGS. In the patient in which, even after a panel, we have no identification, we do whole genome sequencing. In the unresolved obvious inherited case because of the bone marrow failure, so it's still in evaluation. Just to say, we haven't found a lot of mutation using whole genome sequencing in patient with negative tests on the panel. And the problem is that in this, you emerge with many rare variants that are very difficult to interpret in those patients. And we participate to international local molecular board and international working group that share experience, compare the variant, and make consensus on pathogenic variant. It's a long work that has been performed for RUNX1. It is still evolving for RUNX1. It will take a lot of time to perform this in all those genes. So again, to conclude, the landscape of patients with predisposition is expanding. Many patients will not display typical syndromic or familial syndrome. The interpretation of genetic variant is changing, and it is time consuming. It is changing for the physician and thus for the families, and there are international consensus group. There are many ethic issues, and I will not go into that for everybody if you go into genetic screening in the family, but I will be happy to take questions and discuss this if you need. And for that, I would like to thank you for your attention, and I'm happy to take questions. Thank you very much.